say thank you. You may be seated. Good morning to you all. And I'd like to apologize for keeping you waiting. And I can assure you it's not in vain. We had an important meeting in which we had to resolve something quite important. And we're starting later than we had agreed yesterday, if you all remember. We said 10 o'clock, it's 11 o'clock. And this is the reason we have today in our midst, and we welcome them, the advocate and attorneys of MEC, Mr. Dani Mahlangu, who are here with us. And I'd like to welcome you, Mr. Pincus, as well as your attorneys. And in a short while, Advocate Pincus is going to address this arbitration proceedings, out of which you will follow what counsel has to say to you, counsel of the MEC. Advocate Pincus.
Thank you, Mr. Arbitrator.
If you could just put on record who you represent. Yeah.
I represent Ms. Mahlangu, instructed by Bakari Bola Mariana. Thank you. We are here this morning. We've reached an arrangement, and which we have put before you, and it's also been approved by yourself, that Ms. Mahlangu will testify before these arbitration hearings, and the dates that are agreed upon are the 22nd of January next year, 2018, running through to the 26th of January 2018, save perhaps for the 23rd where, Mr. Arbitrator, you're not available. We give an undertaking on our client's behalf to attend the arbitrations during that period, and she will definitely attend. She wants to attend, and we give this undertaking on her behalf. Thank you.
Thank you, Mr. Pincus. I thought you would add the arrangement in relation to the subpoena that will be served on the attorneys.
Yes.
Would you add that, please?
Yes. We've also we've agreed that a subpoena for those particular dates can be issued and can be served on the offices of my instructing attorneys, who are Bakari Bola Mariana, and that can be served at 8A Bradford Road, Bedford View, Johannesburg. That's been agreed to, and we accept that.
Thank you, Advocate Pincus. I'm going to study the normal order that I've followed in this arbitration proceedings to get the response of the various counsel to this arrangement. Advocate Hasen.
Thank you, Justice Moseneke. I confirm that we have had a discussion with the legal representatives for the former MEC, and that we have agreed to the arrangement that in order to avoid a coercive process, to agree that and accept the undertaking of the counsel that the former MEC will be available on 22nd January 2018 in these proceedings.
Thank you, counsel. Advocate Cross.
Thank you, Justice Moseneke. I just want to place on record as well that we are in agreement with the dates that has been reached. We have tried to secure earlier dates, and I'm quite sure my learned friend will be happy to place on record why the earlier dates weren't acceptable and couldn't be reached. Thank you.
Advocate Nguchana. Advocate.
Thank you very much, Justice. Justice, safe for sharing the same sentiments as my colleagues from Legal Aid South Africa. that we invite the representatives of Mrs. Mashlangu just to state and to qualify as to why we came to an arrangement only for the 22nd. I think the families are entitled to know why those dates are only available. So we just invite them to clarify that. Thank you, Justice.
Well, we agreed, angithi sivumelene. Ukuthi no heckling, angithi sivumelene nje. So ngiyacela ukuthi nihlise umoya wenu. Sizama konke sinako ukuba sifike lapho funeka sifike khona. Okay. Are you done, Council?
I'm done. Thank you very much.
You look like you're the popular one because you got the biggest applause.
It's just following instructions, Justice.
Very well. Advocate Kuchak.
Thank you, Justice Moseneke. I agree that the arrangement has been agreed by the parties, and I agree with the sentiments shared by both legal counsel for legal aid and RTSPS attorneys, as well as Adila Asim on behalf of Section 27. Thank you, Justice.
Sure, thank you, Advocate. Advocate Utam.
Thank you, Justice. As we have previously indicated that the government has been taking every effort to make arrangements that all relevant officials are in attendance, the appearance of the counsel and attorney on behalf of the former MEC has been through that effort, and indeed, we have agreed on the dates of the 22nd of January until the 26th of January 2018, with the exception of the 23rd, which is the date on which justice is not available. And that is the arrangement that has been agreed upon, and the matter should proceed on that date, where the former MEC will present herself before these proceedings to assist all the family members and to give information to all the interested parties so that this matter can be brought to finality. And we are thankful for the effort that has been made to ensure that an arrangement is made by agreement. Thank you.
Sure. Advocate Pincus, I think it would be fair to the families that you briefly say why we can only do all this in January. You've had the obvious desire to know why this long, but there is a reason, we know it, but they don't. Would you want to put that reason on record, please?
Thank you, Mr. Arbitrator. We have no difficulty with that. Our client is registered for a Masters of Business Administration at the University of Bedfordshire in London. She has already completed the Mergers, Acquisitions and Private Equity module. She at the moment is busy with the Strategy and Global Competitive Environmental module, which finishes this month, November, and this month she starts with the Global Financial Markets and Wealth Management, which is only completed on about the 15th of January next year. In regard to the question relating to our client's suspension from the University of Bedfordshire, we are of the view that that suspension was both wrongful and unlawful, and we're taking steps to have it revoked and, if necessary, reviewed. That is why, notwithstanding that suspension, she's only available from the 15th. Well, she finishes the module on the 15th of January next year, and therefore the dates that would have been suggested have been agreed upon. Thank you.
Yes, thank you. Thank you ever so much, Counsel. We are done with this part of the proceedings, which we have recorded as we are required, and we're going to get to the next phase. So at this stage, nizwile ngithi abantu bakithi ingcaciso ikhona nizwile. Does not mean you have to agree with it, but that is the arrangement currently, and we're going to have to wait, and good things are often worth waiting for. So we're going to wait because we have to get to that evidence. And I ask for your patience and your understanding as we continue to do the work we have to do in these arbitration proceedings. Again, I thank you, counsel and attorneys who are here, and you are indeed excused. Thank you. I do not propose to take a tea break given the late start, so we're going to go straight ahead until the lunch break. And we have important evidence to go through today, and that's exactly what we're going to do. Evidence leader.
Thank you, Justice Msaneka. I'd like to call Professor Makgoba to come and provide us with some explanation to certain questions which were raised during his testimony, and further inquiries which were directed at him in relation to the numbers of patients who died and other issues which will come and explain. Before he comes, let me also record that today I'm flying solo. My colleague is outside of town consulting with a witness.
Yes. And the professor is going to hand in the report formally, is it? Yes.
Correct,
Very
correct.
well.
It's not a report, or it's not a final report, but a report in which he explains the questions which were raised to him.
Yes.
The final report has been done, dusted some time ago. He had testified on it.
In which language do you prefer to testify, Professor Makgoba?
I will do it in English.
In English. Would you again put your full names on record?
It's Malegapuru Makgoba.
Do you swear that the evidence you are about to give will be the truth and nothing but the truth? And if so, please raise your right hand and say, "So help me God."
So help me God.
Counsel.
Thank you, Justice. Professor Makgoba, there is a document in front of you which you have prepared. We have referred to it as ELA 57.
Yeah.
Are you on it?
Yeah, I can see it.
Yes. Can you take us through the document? I see that on the second page, under introduction, you introduce it by the following: that following my oral evidence on the 9th and 10th October 2017, I received a number of queries from Advocate Adila Hasim of Section 27 and Advocate Kunewald of Solidarity. It's in fact Herta Spears, attorneys. About diseased patients who did not appear on my list. These similar queries were subsequently raised with Dr. Ernest Kinoshi, acting head of Department of Gauteng, Department of Health, on the 20th of October 2017. I was thus requested by Justice Msaneka to consolidate all the figures and provide a report. Accurate figures are essential to the arbitration process. This is an explanatory report following upon the inquiries directed at you.
That is correct. Again, I want to emphasize that this is not my report. I've already done my final report.
Yes.
And my final report has legal requirements that I need to fulfill. So I did this out of a request from what I testified here. So it can never be my report, but an explanation. Again, I want to go back to what you've just said, that during my testimony here on the 9th and 10th, I received, I think, a list of deceased patients that were not on my list, and I can explain that. And I was asked to go and look at this list. I had received about 15 names, I think, from Section 21. I had received 2 additional...
27.
Yeah, from section 27, I've reduced their status to 21, yeah. But from section 27, and I had received 2 additional names from Advocate Groenewald, and I went back to Dr. Kinoshi, who is the acting head of the Department of Health in Gauteng, who obviously is the custodian of the patients that were being looked after, who also supervises a data verification team that has compiled the list of patients that were being, I think, looked after by the department. I also took the opportunity to go to the CEOs of the hospitals in which patients were distributed into. And all of those people, including Life Esidimeni, I went back to the new CEO to find out, to give me the list and verify the list of the patients that I'd received from the 2 advocates. And all of them, I think, cooperated in this matter. I then looked at the terms of reference for the arbitration, and they are covered under the title Entitlement Criteria, which is, under that there's a section 2.1 and 2.2, which marks, I think, the terms of reference. And in short, it says that all people that died before the 30th of June or a month after the relocation process should be included in the list of those that are eligible. And I prepared my report with this in mind. And as you remember, the original was to prepare this report and only send it to you confidentially without sending it across. And that's what I did, but I actually did indicate that I'm prepared, I think, to put it on the record if that was necessary, and that's maybe the reason why I'm here. And clearly, I'm now going to say how I have prepared the report, because you might have to look at it.
Yes, let's start at, that is on the same page 2, under I provide the report organized as follows.
Yeah. I have made a summary table of the official figures in accordance to the terms of reference of the arbitration process. That is section 2.1 and 2.2.
Well, before you go far, I'm intrigued by a scientist who codes poets and other writers.
I'll come to that.
Oh, you will come to that?
I'll come to that.
Okay.
It's just the way I do things. The second table is, I have gone to each facility where people have died, and I have provided a table for each facility as to the number of people who died. But not only that, I provided that table from the time of the marathon project. So for each facility, I went since October and say, how many people died here, who died here, and it's provided as a table so that for each, you are aware of when did a person die, in which facility, at which month, up until September 2017. So from about 2015, for each facility, I've done that per month, and the table is included as part of my document.
Yes, let's get to it.
Basically, I can just summarize it as follows. That if you look at the table, which you might have or you might not have.
Let me do this for the record. That is, under A, you make reference to a summary table of the official figures in accordance with the terms of reference of the ADR. Under B, a summary table of total death per facility and period in accordance with the terms of reference of the ADR. And C, a detailed spreadsheet of all deceased patients up to 30 June 2017.
Yes.
Then under D, in addition and included is a list of 4 deceased patients highlighted in yellow up to 1st September. That should be end of September.
Yeah, end of September. Yes.
The 1st of September it's an error.
Typo. Yeah.
So up to the end of September 2017.
Let me summarize.
You'll explain that
let me
later
just
on.
summarize it as follows. That in order to to start this, we had to study the total number of patients that were at Life Esidimeni at the beginning of the project. And the data verification team went through close to 10,000 names from various data sets that were provided from my office, from Life Esidimeni, from social workers, from hospitals, including the Home Office, SASA, and others. So they went through that list to compile the total number of patients that were at Life Esidimeni. And we have come...
That would have been around May, June, no, around April, May 2015.
It would have been from the beginning of the project, would have been October. So how many people were at the beginning of the project when the project started?
I see.
And that number, for the record, is 1,711.
That's around October 2014, the number
No,
would
2015.
2015.
The total number of people that were at Life Esidimeni was 1,711. That's where it starts. And 270 of these patients were discharged home. 270 were discharged home. Now, again, I want the media to report things as they are said rather than to report things as they are sensationalized. I really, that's why I'm going through this trouble. So 270 patients were discharged home, leaving us with 1,441.
I'm sorry, Professor. Which we're looking at the schedule on.
It will be page 3. It's just a summary of the results, really.
Let's go to page 3.
Page 3.
Is it page 3?
Results.
Yeah, sure.
Yeah.
I'm just trying to follow you as you say it. If you have a schedule at hand,
Yeah.
it makes my life a little easier.
Okay. Maybe I should just say on page 3 under results, I just want to summarize it because I don't want to confuse people with the details. So we're starting with 1,711.
Yes.
We discharged 270.
Yes.
We remain with 1,441. This is arithmetics and not maths. Now, then I'm requested to look into the circumstances of the death of mentally ill patients in Gauteng. As the Ombuds, I do these investigations from October 2016 to February, the 1st of February 2017. And in that period, I find that there are 118 patients that died. And that figure has not changed. That is the terms of reference that I followed. 118 died during the period when I was investigating. Then I look at the terms of reference of the arbitration process that says I must then look at the death that occurred up to a month after the relocation process. So when I finished my investigations in February, patients were still in NGOs, some patients were in hospitals, but I had made a recommendation that all these patients must be removed from these unhealthy places or unprepared places back into safe places where they could be taken care of. So that process started after I had released my report on the 1st of February. And the process started from there and went up to the 31st of May. It was the process of relocating patients from unhealthy, unprepared, unlicensed NGOs back into high-quality healthcare places. And patients continued to die during that time. And then, after that, I would have to count from the 1st of June to the end of June, which is the month that is allocated as part of the arbitration.
Yes.
Now, what is the figure for that? The figure for that period of arbitration is 128 patients that died from Life Esidimeni and 11 patients that died from the associated death that I've spoken about in my previous, bringing the total to 139. So
And those are items E and F on
yeah,
page
they will be
3.
they would be on page 3. That would be item H, where in total there will be 139 patients that have died as determined within the ADR arbitration terms of reference. Now, again, remember that whatever we count as Life Esidimeni or as the project, there are always these 11 patients that were associated death that died at Siabadinga, Takalani, and even at Precious Angels. They were associated because they didn't originally come from Life Esidimeni. They were either they belonged to the Kalinen Care Rehabilitation Center, but then had to sacrifice their lives in place
Yes.
of Life Esidimeni.
That's the category that was displaced from CCRC, but were associated because they had to give way for
Yeah.
those who had been moved from Life Esidimeni.
Yeah.
Yes.
So basically, for the period of arbitration, the total number of deaths is 139. For the period of the ombud is 118. Now, remember that Dr. Kinoshi and his team have been monitoring patients, and we have monitored these patients up until the end of September. Now, by the end of September,
Which year?
2017, there had been 4 additional deaths, which brings the total to 143. Now, I want to talk about that because there is something that I actually want to share with the families and with the lawyers.
Before we get to that, then that means you must correct the reference to 1st September under I on page 3.
It's 30th of September.
Yes, 30 September.
Yeah, I think it must be corrected on the record. Then because I have provided you with a table of facilities and the number of deaths per facilities over the period, I have also given the final figures for some of the facilities that were identified. And I want to place that on the record that at CCRC, 29 patients had died. 29? And remember that CCRC is a complex that involves Anchor and Siabadinga and the Kalinen Rehab. So there are 29 in total. And at Mosigo and Takalani, which are also a complex, although they are separate, they have the same director. One has got a license, the other one has got is running under the other one. There are 38 people that have died from Takalani in total. So they have now outstripped even Precious Angels, which had the highest number, which is still 20, and not 23 as I've had it on evidence. It is 20. And then there is Tsepong, which had 13 deaths at the end of what I was doing. In total,
I'm a bit confused by those numbers. I'm looking at a summary on page 3 under item A.
Yes.
Is that where I should look? Are those respective numbers? In other words, CRC, the numbers that follow,
yeah.
if you set out respectively, are they?
If you go, Chief Justice, if you go to this little table here.
Professor Makgoba, before you go there, let's go back to page 3.
Yes.
There is under the next column a summary table of death per facility and period showed.
Yeah.
Are you making reference to that under A?
Yeah, it's under A.
Yes.
It's basically, it's a summary table of death per facility.
Yes.
And the period that I've showed on page 3 under results.
The first number 29, you link it to CCRC.
Yeah,
That
it's respectively. I left maybe the word
Yes.
respectively. It's 29 for CCRC,
38
for Mosigo and Takalani,
20.
and then 20 for Precious Angel, and 13 for Tsepong.
That's correct.
Those were the high density places where
Yes.
people died. So out of the 139 patients that died in my investigation, 100 of them had died from these 4 places.
And
Yes.
that's where the 72%
It's
comes
72%, but then if you were to add the 11, because they would have died at CCRC, it becomes 79.85. It's
Yeah.
closer to 80.
Then
On B, I've just put a footnote that we must remember all the time that CCRC included the 2 unlicensed and poorly prepared NGOs, Anchor and
And
Siabatinga.
Siabatinga.
yes.
Okay? So that is the numbers.
Then your statistical analysis.
Now, the statistical analysis, as you remember, in my report, I
know
had
you're going a little far. For details, we should then look at page 8 of the report.
Yeah.
It's a very vital thing. I'd like to make sure I get it right. So, what you've summarized on page 3, A and B, in effect, the detail would be found on page 8. And the schedule that says total death per facility.
Yes.
And period.
Yeah,
Is that right? Okay.
it's provided there, yes.
Sure.
Okay.
Thank you.
Perhaps you can finalize your explanation on or in relation to page 8.
I think in relation to page 8, as I said, I have just put in where patients died, the name of the facility at the top, and I have put the period from January 2016 up to the end of June, which would be the arbitration period. And I've put for each facility when patients died. So for example, you will see that for CCRC, nobody died in January 2016 up until June 2016. Now, all of you know that in June 2016, it was when the major migration was taking place and people were being transferred from Life Esidimeni into the CCRC. And the same pattern you can see for each of the facilities, that the death almost in numbers began to follow from June 2016. And that is what it shows there, and then it follows for each month up until June. For CCRC, for Mosigo, for Precious Angels, for Tsepong, and so on and so on. The list goes on.
So according to that list, the first death occurred in January 2016.
Correct.
From Tsepong Care Center.
Yeah.
The numbers I don't understand are numbers like Life Waverly, well, late.
Those.
For instance, in April 2017.
Yeah, because people were now being moved back into places like Waverly, when the relocation process took people back into Baneng, which was part of Life Esidimeni, and Waverly. So they had to be counted because the period of arbitration says that we must go up until June.
Up until June, I
Yeah,
understand that.
yeah.
So they would have had a round trip, so
Yes,
to speak, to
yeah.
be moved out,
Yes.
go wherever else,
And then come
escape
back.
death, and then come
Come
back,
back, yeah.
to Baneng or Waverly.
Yes, that's correct. So that is that table there.
That's
And for the sake of clarity, again, I've divided it into the period of my terms of reference and then the period of the arbitration, where at the end of my period, there were 118. It's there in green. And then at the end is the final tally, which is, I don't know what color is this because I'm colorblind.
on
but
page
it's
9.
on page 9.
Yes.
It's 139 and it tallies. But as I say, it is really the facilities, death per facility per period over the time of the arbitration period. So you can go there and say, I want to see what happened in Waverly, I want to see what happened in Mosigo over this particular month, and you can see how the deaths are clustering over a particular period.
That is where you record at the top. Total after the release of the Ombuds report,
Yeah.
it's equals to 21.
Yeah. So after I released my report, up to the time when patients were relocated, 21 patients died. And if you then add them to the 118.
That's where 139 comes from.
Yes, that's where it comes from. That's all but I think the media must be very careful when they report. I think they must report the numbers and qualify them according to the period and the terms of reference, because otherwise the population gets confused and they think that somebody is hiding something. We are not hiding, but there is a time-dependent and terms of reference-dependent way of reporting.
Sure.
Yeah.
But you were quite clear from the beginning that you were still counting.
Well, yes, yeah. I was clear about that, and there was a reason for that, and I've explained it that at the time of my investigation, it was clear to me that information was coming in, and sometimes I was not being given information at the time when I was looking for it. And I also had evidence, but I hadn't verified it in the manner that would be satisfactory for me to actually pronounce it as authentic or something like that.
Well, let's put it this way, Professor Makgoba. When in the end 143 people die, I know there are different three stages. 118, an additional 21, and ultimately an additional 6, that gives you 143. Part of the horror is that you even have to reconcile these numbers in this complicated way, which gives an idea of just how many people have died. There are many bodies, aren't there?
Well, I think, yes, I think I would like to agree with that, Justice. I just think that this is like a moving train, and that's why I want the media to be very cautious, because, you know, people are coming out of the woodworks in different ways, and they appeal to different people. You know, I suspect that it may be that even after what I've said today, you may find that there are people who need to follow a different process in order, I think, to bring this. But that is really not within my gift and within my terms of reference. It is something that maybe the arbitration process needs to sit and discuss, because I followed a particular process with particular terms of reference, and there is a particular outcome, and I can stand at the rooftop and say, this is what I found from the information that I have that is authenticated. As I say, this data here comes from the Home Office. There was a name here that was actually raised by Section 27, where somebody's name was spelled as Lehwabe with a G. Now that's Bedi. Now if you spell it in Xhosa, you can put R and it becomes Lerwabe in Sotho, but it will be Lehwabe in Xhosa because their R's are pronounced as. But it was not only that, but even the dates of death were different. So you had two things that actually made it different. We had to go to the Home Office to ask, is there such a person in the Home Office register? But we also had to go back to the hospital and ask them, did you ever admit, who did you admit who died in your hospital? And this was at CCRC.
So the schedule that follows next,
yeah,
you're going to take us there sometime,
yeah,
right?
I'm going to do that.
Beyond the one whose color you can identify.
Yeah.
You're going to tell us more about, okay, let's go there then.
Okay. Now, the final schedule, which is on page, there is a page which would be.
I'm sorry, just before you go away, Professor, of course, you won't be surprised when the media says the number is now 143.
Yes.
And that would be borne out by the different stages of counting that you have so ably done, and we're grateful for that. So clearly, you know, you're going to have to expect the media tomorrow to say, Professor Makgoba says, no, in fact, there are now 143.
I expect them to qualify it, Judge. I really think we can't just bend in numbers around. I think the media must not only inform, it must educate.
Yes, but let's go to the schedules. Let's get back to the numbers. Yeah.
I think the following that, there is a page which is just really a breakdown of the numbers, and I think this, I leave this to the arbitration team to argue about and so forth. It's not really for me to go through. It just spells out the numbers that I've already said there, and I don't think there's an issue around that. And then there is a schedule of the names. It's almost like a 5-page of the names of the 143 divided into 3 sections of the 128, which are the Life Esidimeni patients that died in accordance with the terms of reference of the arbitration. And then there are 4 additional patients that are put in yellow that died almost towards September and after the period of arbitration. And then there are the constant 11 that have died as associated death covered on the last page. So that's really the table, and it's the details as far as I can see from what I have. I've given the total breakdown, and I've given the names, the list, where they died, and where they were admitted.
Professor, this is very impressive, but I mean, as far as you know, with the work you've done, the detail on this final schedule, the details are reliable. They are.
As I say, they've been verified by the data verification team in the Department of Health.
Yes.
They've been verified by my office. We have checked this, as I say, with the Home Office. I've done that myself, and I know that the Department of Health have done it independent of me. They have checked it through SASA. We have checked it through another team called the relocation team that was also monitoring these patients. And we have gone back, as I say, to the CEOs of the hospitals where these patients were. We have had to make some alterations here and there, but this is where we are. Now, there is a point that I also just want to clarify that I've just, and I'm speaking here as a doctor, for once, not as an ombudsman. When a patient comes to a hospital or is referred to a hospital, the patient belongs to a doctor or they belong to a clinic. Now, I say this because the patients we're dealing with here were patients that came from Life Esidimeni. And the decision was that the patients will either be discharged or they will go to a hospital, an institution hospital, or they would go to an NGO. Now, you will discover that when you look at the places of death, you will find that somebody will have died at Kalafong.
I see some adverse copies.
Yeah, no, adverse copies it's legitimate because that's where people were going to go. You just have to count it as a place where people needed to go. But nobody left Life Esidimeni to go to Kalafong because Kalafong does not treat long-term mental health. But somebody would have gone to Precious Angels, for example, and got sick there and then was requested to go to Kalafong. Now, in health, the place where you register is the place where you belong and you are treated through the system. So if you are treated and you die at Kalafong, or if you get better at Kalafong, you are going to go back to the NGO where you came from. You are not going to come out of Kalafong and be discharged because remember you are a long-term patient. You have a place that you are registered at. So the NGOs where they were registered would be the place where they belong if they had been treated at the hospital. So these things should not be confused, that you see somebody at Leratong Hospital and you suddenly think, oh, they belong to Leratong. They went to Leratong for a particular reason, maybe for an emergency, for something like that. If they got better, they would have gone to the NGO or the hospital to which they are now registered. And that's a tradition in the health system, that the place where you are registered tracks you around. You know, when I was in London, I would see people from Edinburgh And they will be coming from Edinburgh, but when I finished with them, they go back to Edinburgh. They belong to Edinburgh. They don't belong to me. They came to me as a referral and so forth. So I just want people to be cautious about, otherwise you'll have people all over the place and you don't appreciate it. It's a tracking system within the health system that is actually quite classic and traditional.
Professor, where the schedule is silent about the location of death,
Yeah.
what assumption should I make? That they would have died at the facility registered at?
Yes, they would have died. I mean, there is one here that is actually unknown, and we have been struggling to find what is this unknown. And as I say, out of that whole list, obviously we have one that is unknown, and we have tried our best, and we have come back. The best way to register it is to leave it as unknown, because we
Yeah.
can't assign it.
But look at the location of death on the schedule. You'll see there are quite several where the location of death is unspecified. So my question is it legitimate to assume that it would have occurred at the facility
At the
registered
facilities,
at?
yes, it is at the facilities, yes. That's a reasonable assumption to me, yeah.
Councillor?
Yes, Professor Makgoba, just to finalize on your report, let's go back to your statistical analysis.
Yeah. As I indicated in my initial report here, was that one of the problems we had was we had problems of records, registrations, and numbers, and therefore, when we went to the statistician general to say, can we analyze this to find significance, to do t-tests, statistical t-tests, he said, no, you can't do this, because this whole thing shows such poor administration, there are no records, and you don't know whether you're comparing apples with sugarcane or oranges, whatever it is that you're doing. But basically, we couldn't do robust statistical analysis. And part of the reason why one of my first recommendations to the Gauteng department was to go back and say, let's try and find a way in which we can reconstruct, I think, the data from scratch and find out who were at Life Esidimeni when we started the project. And that's why we went through this data verification team using computers and going through about 10,000 records and names. In fact, at one stage or another, for the lighter side of it, I had patients who had 2 days of death, 28. Now, I know one thing about South Africa that they often did. One of the things they did, which is laughable in the world, is sometimes we confuse genders of babies when they are born. You call them boys or girls when they are girls, you call them whatever. So we are very good at mixing up things. But to have 2 days of death and you have 28 people, it shows you how corrupt the data was so we had to go back again to the home office, to the various places, and say, what actually is the actual death? Nobody can die twice. And then we had people who had several IDs and so forth. I'm sure you have heard about that. So we've had to clean up this data to come to where it is right now.
Yes.
So now we're able to do statistical analysis.
And that is the result of the cleanup.
Yeah, this is part of the cleanup. And then now I just want to share with you the statistical analysis, because I think this just drives home some of the things that you may want to hear. First of all, we looked at the patients who died in 2016. That is from January 2016 to December 2016. The reason for that is that the Statistician General in the country compiles an age-adjusted record for the country that in 2016 from January to December, so many people died, and so many people die per 1,000, because that's how it is worked out. So the population, out of the population of South Africa, you have a number of people who died, but you have to calculate it per 1,000 of the general population. So in South Africa in 2016, for every 1,000, 8 people died. If we take the people who died from this transfer. There were 106 of them, and per 1,000, if you work it out and compute it, it was 63 per 1,000, which is 8 times. They were dying 8 times higher than the general population, which is very significant. Okay? That's the first point in the statistical analysis.
And the second point?
The second point is, if you then look at the observed death of this group that we're studying, and you compared that observed death with the general population, you came to something called a standard mortality ratio. And the standard mortality ratio that was able to be computed by statisticians is 4.9. Now, how do you deal with this? We went through the literature and found that there were 203 studies that were done in 29 countries and in 6 continents, looking at the standard mortality ratio. And the average for the world is 2.2. So ours of 4.9 is very high. For this population that we studied in 2016 that died.
And is this the standardized mortality ratio
Yeah.
of country or of the cohort?
Of the
here?
cohort that we studied for 2016 that came out of Life Esidimeni, comparing it with the international benchmarks of
Yeah.
203 studies in 29 countries.
I follow.
Yeah.
So it's also country code. It is Esidimeni,
Yeah.
Life Esidimeni code.
Yeah.
Yeah. Okay.
And then we did other studies statistically that showed that when you were transferred,
Just to get the point nailed there, this code was 4.9 compared to the international benchmark of 2.2.
2.2. Yeah.
Okay, I've got that. Thank you.
Now we looked at the risk factors. So what were the risk factors for people to die? We found that there were 3 risk factors. If you were transferred to an NGO, you died faster and earlier than if you were transferred to a hospital. Okay? Now, let me put it in perspective. If you were to look at patients who were transferred and look at them at, say, at 92% of survival, 92% of the people who have survived, both at NGOs, and you ask yourself, how many days would they have survived for at the NGOs? It would be about 200 days. If you went to a hospital, about 98% would survive, and it would be for about 400 days. Not only did you die faster, you died earlier if you went to an NGO as opposed to if you went to a hospital. The other one was that if you were older, you died. It was significant. If you are male or female, although it was consistent to see that females were dying faster and earlier, it was not significantly different, but it was consistent that females died in the study. Now, there is a reason for that if you then look at what I've said before. The females in this group were older than the males, so they fell into that risk, and proportionately, they were sent to the NGOs and not to the hospital. It was random, but that's what happened. So
You mean more females were sent to NGOs than males? Is what you're saying?
as a proportion.
As a proportion
Yeah.
of that particular cohort?
Yeah, so,
Okay.
and it wasn't deliberate, it was just, it is what comes out, and it confirms what we had already said, that gender and NGOs versus hospital. So that is actually very significant also. So the final one on the statistical analysis is that if you had gone to an NGO, you had a 3.5 higher risk of dying than if you went to a hospital. Again, confirming that there was something that was not right about the NGO. Now that's really, as I say, this is not done by me, it's done by statisticians. So that is the next point I wanted to put. So if you were older, you were female, and you went to an NGO, the chances are that you had your survival is cut off. And the figures are there.
Yes.
Now,
on page 4, I think we have dealt with this earlier.
I dealt with this
in
before,
your evidence,
but I want to emphasize it because it has got. We have spoken about this whole issue of people dying in the winter, and I just want to summarize it as follows: that this is nothing clever, but if you were to look at the history of Life Esidimeni and look at the history of the population in general, we know that there are more people dying in winter. So, as it happens by coincidence, the transfer of patients out of Life Esidimeni, the maximum transfer took place between the months of May and June. That was when the maximum happened. And that also coincides with the winter. So if you looked at the months of May, June, and July, and studied the number of patients who died in Life Esidimeni, and then you compared them with the number of patients in the same period who died in the facilities, and then you come back in 2017 when you have relocated them, and we've relocated them almost coincidentally around the same time, a very interesting picture emerges that over that peak period of 3 months, at Life Esidimeni, you had about 12.8 people dying per month, just between those 3 months. If you then went during the marathon project, 22 people died per month in that period. Okay? Then you take these people back to good quality care in the hospital, 2.7 people die. What does it tell you? Is that look after mentally ill patients properly, professionally, at the right places, nobody dies, or very few people die. So it's basically the best proof of the pudding, that if we had looked after these mentally ill patients, we wouldn't be sitting here. Now let me put it this way. In 2016, 103 patients died from January to December. In 2017, in 2016, 103 patients died. In 2017, now, it is the 10th of November, and we have only had 29 deaths from January to November. Now, this is again arithmetic and not actuary. If you subtract 29 from 106, we have lost about 76 or so patients that should not have died. That would have been here. I mean, as I say, if you do actuary, it may be less. But basically, as we see it right now, we have lost about 29 as compared to 106. And the difference is people we should not have lost.
Yes. And I see that, I think just explain, I think this would be important as well. Item 7 on page 5. Just explain that for the record.
I said that during this period of transfer, and especially these 3 months, and as I said, this is just a snapshot, a window, and it follows a number of coincidences that the transfer occurred in May, June, July, and Life Esidimeni deaths were often maximum between May, June, and July, and then we did the relocation during May, June, and July, and you can measure that. It's just a snapshot, but it gives you something. That there was a 72% increase in death in the facilities during that period. And we also know that during this period, we closed about 6 of the NGOs. They were closed because people were dying there, and both the minister and the premier obviously were worried to prevent that we don't suffer more death by closing those NGOs and transferring them where? Back into the hospital. So, and then after that, we did what we didn't do before, which was to call experts to come and supervise the transfer into the hospital.
That is after the closure of this.
Yeah, after the closure of the NGOs and the relocation process, then we had the death decreased by 98.8. That's how significant it was. It just almost precipitously dropped.
So this will be the period after closure of the supervised relocation of patients back to either
proper place. But all that it tells you is that if you look after mentally ill patients properly, professionally, and give them good care, they are able to live. And that is the message here. And as I said, the proof of the pudding. Now let me.
So this will be a contrast to what occurred when they relocated the
Correct.
patients from LE to the NGOs.
Yeah, and there is too many evidence here to suggest that our NGOs were, first of all, not prepared. They were not properly governed. I mean, they had other issues that you might have had here when you were sitting and listening. But there were lots of problems. But if you take mentally ill people and you put them and look after them professionally and well, they are able to live as they have done. Now, I just want to basically close up and conclude my thing. And this is where I suppose, Justice, I come to a little bit of poetry, but let me deal with the facts. First of all, we now know that to have maximum impacts on death in South Africa, we have to target the months of the winter, especially with these mental ill people, because either, they get out at night, they just stay outside, and they need to be properly looked at. We need to target those 3 months properly. And I think there's a story at Life Esidimeni that they did that. But for me, the most important message is that unnecessary death can not only be prevented, but can also be stopped through professional quality health care, as demonstrated by studies at Vescopis, as shown by the low deaths in hospital versus the NGOs, because there's professional care there, but as also shown by the dramatic decrease and the significant low death in hospital following the expert-guided relocation and professional care. It's all about professional care and where they are being looked after. For me, this is the clearest proof that these were not only unnecessary, but could also have been so easily prevented if we had given them the professional care that they deserved. And again, I repeat that the hospitals such as Vescopis, Sterkfontein, I think they did a wonderful job, I think, in looking after patients. So I now then have to come back and say, I use this quotation for what it's worth. And it comes from Shakespeare. It says, "Now is the winter of our discontent."
So there would have been nearly, 4.5 times deaths at NGOs than at Vescopis and Sterkfontein.
Yes, correct.
Yeah.
Made glorious summer by the son of York. This was coined by Shakespeare in 1594. But the winter of our discontent obviously summarizes often a period in a country of unhappiness and so forth. And it's often also a time for philosophers and others to reflect and see what can we learn from the lessons of such disasters. And I think part of what's going on here is really to see whether out of this unhappiness and I think disaster that we've gone through, whether there's light at the end of the tunnel, as long as it doesn't hit you of this train. So I use that just to remind us that, it's not the end of the world, but we are going through a very difficult time. Then I'm saying again, unnecessary and preventable death of mentally ill patients occurred in Gauteng as a consequence of reckless and negligent decision-making and actions. Now, in Lord Tennyson's poem, it says, somebody had blundered. Now, you must find out who had blundered, but you will deal with that. That's why you're having this process. But again, I want to emphasize...
neither you nor me are poets or philosophers, Professor.
No, but also...
You're a doctor, I'm a lawyer.
Yeah. I also want to emphasize that let's not paint all the NGOs with the same brush. What happened here, I've demonstrated to you that 100 out of 139 occurred in 4 or 5 places. And we must understand why particularly those 4 or 5 places. So it's not every NGO. I'm not saying that they don't have problems, but certainly in terms of this death, it's not there.
But isn't there also an issue of proportionality? I mean, the smaller NGOs, how many warm bodies did they receive? Let's look at your schedule. I just wondered, look at the schedule on page 8. Do we know how many NGOs would Thuli Home had received? I mean, how many patients?
I don't know this, but I do know that I can say this certainty. The NGOs generally where there were fewer deaths were NGOs that knew what they were doing, and they refused to take more patients. They would refuse. They would not be seduced to say, the more you take, the better your reward would be. They would say, no, we are capable of doing this. We are not capable of looking after so many patients. They would refuse.
Yeah.
That's why I say these 5 and others, there must be other reasons that I think you can explore.
So the valley of death coincided with the number of people.
Yes.
Concentration of patients were taken into these facilities.
Well, it coincides with that. But remember that when you take more patients and you don't have professional staff or qualified staff, basically you subject them even to almost, we may call it double jeopardy or something like that, but you are just compounding the problem that you have. You don't have qualified staff, they are not good at what they are doing, and then they've got more patients to look after, and the problem gets worse rather than gets less. And I think you might have heard that during. So then I say, I think you all have heard this during the course of your thing, that during the course of my investigation, many staff from the department said that, they feared what was happening. And again, I return back to Lord Tennyson when he wrote The Charge of the Light Brigade. And I thought I would read this for this audience. Forward the Light Brigade. Was there a man dismayed? Not though the soldiers knew someone had blundered. Theirs not to make a reply. Theirs not to reason why. Theirs but to do and die. Into the valley of death rode the 600. That's what happened here. And again, I can remind you, for those of you that are students of history, you remember during the TRC, there was a lady called Kolati Falati. She testified, and she used this word, that hers was not to us, was not to reason why, but hers was to do and die. That's what happens when you operate like that, out of fear. Now, again, finally, I want to simply say that I think the national minister, the premier, and all the professionals and the staff that were involved in this relocation process have provided what I call care, and they've complemented, I think, for bringing back dignity and pride to South Africans. You remember when Barack Obama was campaigning, he kept on saying, yes, we can do. And I think this relocation process has galvanized people together and has shown that we do have an infrastructure of how to look after mental ill patients, provided we do it correctly and we follow what we have. So I think it's very, very important to think about that I think the interventions of the Premier and the National Minister, and by galvanizing the resources that we have, was able, I think, to bring people together, to focus on the mental ill patients, to actually reduce the death, or the value of death as it's called, into small numbers or manageable numbers that we can all deal with. And that's why, since the relocation, only 7 people have died. 7. I mean, it tells you the degree or the magnitude through which, by just caring, you can deal with this. Now, there are 2 issues here that obviously, if you you like figures, you will have seen. I've shown you that 12.8 people would have died at Life Esidimeni. 22 died during the marathon. 2.7 died when we relocated. What it tells you that even what was happening at Life Esidimeni, although people were comfortable with it, all of you, I've heard people say that people were being looked after. The quality of care by international benchmarks is not that good. But nevertheless, in South Africa, we are used to suffering, we are used to being abused and so forth. So our threshold for what is quality is problematic. And I just want people to, so when we are moving forward, we must be aware of quality and demand more rather than accept that what we get is adequate.
What will be the threshold?
The threshold,
Acceptable.
The threshold is, we have a hospital in South Africa called Vescopis. If you go and study their mortality of how they look after mentally ill patients, it's a benchmark. In fact, any mentally ill patient in the world is much safer at Vescopis than any other mental institution.
2.4% you're talking about, is
yeah,
it?
yeah.
Mm-hmm.
They would be much more comfortable. If I was an American and I had a mentally ill patient, I'll send them to Vescopis, not to Wisconsin or any place like that. So the benchmark is there, Vescopis. It has done studies, it has looked at a mortality rate after 4 years, and so forth. So if we are going to deinstitutionalize as is national policy, we have to bring the NGOs to the standards of a hospital like Vescopis. At the moment, I think that journey or that gap is too far. But I think on that note, Chief Justice, I just want to say and end up with Mahatma Gandhi again, who said the true measure of any society can be found in how it treats its most vulnerable members in that society. And basically, I think if we can take that as a benchmark, that we had a population of vulnerable people, and obviously, as the state has already conceded, I think there were things that were not done right, but the only way we are going to measure ourselves in the constitution that we have, one of the best and envied constitutions in the world, is really how we treat and look after the most vulnerable people. Now, obviously, I know that the lawyers have not yet studied this, and I'm very glad they haven't, because then I won't be asked too many questions. So I'm happy for they can do that when I'm gone. But generally, that is really a supplement to what I was asked to do, and to say that I think we can do it. We do have a small infrastructure. Let's exploit it. We don't have to do it kicking and screaming like we're doing it right now. Thank you.
Yep. Well, where I work, we don't have applauses. Never had anybody applaud in a court or in a formal hearing, but what will I do? Think you like what you heard from the professor? Well, we're going to get on to the cross-examination. Advocate Hassan. Thank you, Professor. I'll thank you at the end. There might be questions to you, and we should get on with that.
Thank you, Justice. Thank you, Professor Makgoba. I want to say that we are indebted to you for the attention you've paid to this tragedy and to the rigor with which you've approached your task. This is a very important and important report for the process and to enable us to do what we need to do as representatives of the various parties here. We are indebted. I just have a couple of questions. The first is in relation to the name Lekwabe, Motofela Lekwabe, as you referred to in your evidence in chief. You went and took some time and effort to double check that entry. And it seems to me that it was, in fact, a double entry, that it was the same person's.
Correct.
And that's now been corrected. So we're glad to see that. The second question I have. So that wasn't a question. I wanted to just
What
confirm.
number is it on the schedule?
It's
I think it was
number 50.
It was 49 and 90, somewhere like that, in my initial schedule.
In the initial, and in this one, it's on page 3 of 6, and it's number 57.
Thank you.
Motofela Lechwabe. So it's not really a question. I'm just confirming that I understand it correctly. The second thing is, you said that where a patient, these were your words, where a patient is registered is where the patient belonged. Would you say that once the patients were transferred from Esidimeni, that they belonged anywhere?
No, this is the point I'm trying to make. Esidimeni was closing as a health service provider. And it had to be decided, what do we do with the patients at Life Esidimeni? So it was no longer going to exist. And the decision was, we do it in 3 ways. The patients that leave Life Esidimeni, because they are state-assisted patients that are long-term patients, we can either assess them as fit to go back to their homes, or we can either say they require medical treatment and then they would go to a hospital, or we say they are fit to go to an NGO. Now that is the 3 areas. Once you have transferred them there, they would be registered there. But remember that there was always an arrangement between the state long-term mental hospitals and NGOs. So if somebody was transferred because they were sick to Vescopis, they would go there and Vescopis would assess them whether they were ready to be either discharged home, which is what happened, I think, as part of the process, or it would say, maybe they are now fit, let's go and assess an NGO where this person can be put on for the long term, which is what has been.
But what is the short answer, Professor? I thought the answer was, well, then they get registered at Siabadinga or Takalani.
Yeah, they get registered there, provided you are registering them at a place that is properly assessed, properly licensed, and has got legitimacy. You don't register them in a place that takes the constitutional need to have health. You don't do it. When you do it that, you are negligent.
Let me clarify what my question is. Would it be correct to say that even once they discharged from Esidimeni into other facilities, they're not discharged, the use of the word discharge is not that they're cured.
Yeah.
They remain in the care of the state, even if they're at another facility.
Correct.
That's correct.
Yeah.
The second complexion of my question was about the use of the word belonging. And what I'm suggesting to you is that it's not only belonging in the sense of there's a number that follows you and that tracks you because you are in the care of the state, but also because you have a sense that there is a place for you, that you're not discarded.
Yeah.
So what I'm suggesting to you is you use the word belonged, and I'm saying it wasn't only in the manner and the procedural sense of not belonging because their files didn't go with them and there was no number or knowing where they were, but in fact that they were discarded. They felt that there was no sense that they belonged somewhere.
Well,
transfer from one place to another. Where did they belong?
No. I'm talking about there is a patient and there is the professional bureaucracy or the procedures. In terms of the procedures, that's what I was trying to talk about. That patients, when they enter the health system, are tracked through where they originally registered, which is where they belong. And of course, it comes with other things. But for the patient, I think it's a different matter, whether they feel they belong or they feel discarded. Now, that's a separate issue, but nevertheless, I take your point.
I'm sorry, Councillor, let me interrupt you there. These MA numbers, by whom are they allocated?
They were allocated by the Department of Health and the data verification team. And that's a normal thing to anonymize people, because sometimes you don't want people's names to fall into the wrong hands. Now, I don't assume that the hands in which this report is are wrong, but basically that's what we do. We
Yeah.
give them numbers.
I'll tell you why I'm asking. I've seen the MA number used in other reports, like the report from Kalinin. Is it a number that gets, are these numbers, were these allocated by your verification team, or are numbers that followed the patients to different institutions?
I think these were given by the verification team, and they would have been transferred and transmitted to the various facilities. As I say, it's just to protect the names of the patients when you use the MA number. And also when they come to the, for example, when I appointed my team of expert panels, the first thing they needed to do, although they had the clinical records, they needed to give patients a code number or a code figure that they could use, I think, to
You
track.
see at the top you have MHDID.
Yeah.
Is that the ID that's allocated by the state to each patient?
I'm trying to come
You
to-
see, your answer has some importance vis-a-vis the question that Advocate Hasib was putting to you.
It's like
That though they might, people might have been sent to
it's an-
Takalani.
it's an identification number. It's an MHID ID, because it's an identification number. Yeah, that's what.
So it would be on the state's
Yes.
health register.
Yes, it would be, for example, if you went to Dr. Kinoshi's department, he would have these numbers.
And that number would be, would that number ever be allocated to a private patient?
No.
At a private institution?
No, no.
So the number would be indicative of a patient
Yes.
who receives care at a state institution, a public institution.
Yes, correct. That would be what it is.
Okay, thanks. It helps me. Counsel?
Sorry, Justice, I need to follow on from your
Yes,
question now.
Please
The,
do whatever. It just
for-
struck me that as people move around, what is their relationship with the state? It's
But-
a vital point you raised, actually.
Yes,
I'm
but
just
as far
following
as
up on
these
that.
numbers go, I just want to clarify then that these numbers, these IDs, were provided by the data verification team, that it wasn't necessarily an ID number that was ascribed to each patient prior to your process beginning.
No, that's correct. Yeah.
In other words, when people were moved at Life Esidimeni, they wouldn't have reflected that kind of
They didn't.
MHD ID, no?
They didn't have that.
They didn't have that, okay.
Professor Makgoba, you spoke about winter and the importance of that season and the additional vulnerability that it creates. In the first time you testified before this hearing, and then again today, do you think that the Gauteng Department of Health, apart from everything else that we've heard and that ought to have been taken into account in the transfer, should they also have taken into account the season?
I think they should, because I think all of them, I think when I was interviewing them, they seemed to be aware that it was winter period, but I don't know why they then chose to do it during the winter period, but also to do it at the scale and the magnitude and the speed at which they were doing it. So I think I would agree that they should have taken that into account, I think, when they were doing the transfer.
But the question is objectively, should a reasonable decision maker have had regard to the fact that the risk would be higher
Yes.
in winter months.
Well, it's a well-known fact. I think they should have known that, yeah.
Thank you. My final point is this, and that is that you also spoke about the fact that we can become immune to low standards. We can become just tolerant and accept low standards, and we shouldn't. So this is not a question to you, but I suppose it's just for the record to say that many of the families that were represented here and professional organizations did ask for more once it became known that the transfer would take place. And they asked for more in various ways, through letters, through meetings, through protest action, through litigation. And none of that made any difference. Do you have any view as to why that made no difference? You've suggested that we should ask for more in general. My point is there were many requests for more, yet it happened anyway. I'm inviting you to respond to that, if you have any view as to why, despite all of that, nothing happened.
Well, I think in my report, I captured 2 issues and maybe 3, but let me start with the first. First of all, I think there was a feeling in the staff of the department in Gauteng that they were all fearful of, as you go up the hierarchy, they became more fearful. The second is that there was a feeling not only in the department, but generally, if you listen to civil society, to the professionals, to the various bodies, that they were not being listened to. So it was a question of, I don't want to hear that. And I think some people have testified about that. But there is also a much bigger fundamental issue, I think, that is captured in my report, but that has not been actually canvassed, which is, for me, a very deeper philosophical issue. Why do doctors and nurses exist in society? I think people have not asked this. I think it's, I don't know what it's, maybe chapter 3 or so, my report. I've drawn it as a little bit of a diagram. The point I was trying to make in that chapter was that the medical or the health profession stands between life and death. That's our role, whether by omission or commission. The reason why we exist is that our actions, our decisions, our forgetfulness leads to consequences that either places, that accelerates people's death or delay people's death or even improves their health such that they don't die. I mean, that's why there's so much money put into research about longevity and so on, because this profession stands between life and death. Just like scientists stand between enlightenment and ignorance. Lawyers stand between justice and order. In societies, we don't have laws and we have chaotic people. So there is a fundamental question that I think people need to ask. If you are looking after patients or people you call patients, remember that whatever you do, writing letters or so, you are participating in a process that enhances their lives or leads to the deterioration of their life. As I say, I've tried to capture it in one of the chapters in this report, and I think people have looked at it because it's got a diagram of somebody going towards a grave. But the philosophy behind it is that the health department for this group of patients stood between the accelerations of their death or the enhancement of their lives. And I think you can pick your choose as to where you think they fell when you have listened to all the evidence.
The statistics you gave us show us that there was a significant acceleration towards death. Counsel?
I can reassure you that there are other experts that will be coming to testify from the perspective of ethics and from health professionals. So maybe your challenge, as you put it in the report, will be taken up there. I have no more questions for the witness. Thank you, Justice.
Before I call the next counsel, you know, Professor Makgoba, yesterday I was organizing quite loudly about the evidence that tells us that aside from death having occurred in these circumstances, witness after witness from the family told us how there was nobody there present to say how their loved one died. Sometimes there's no one to tell them where, when, of what they died. And you know the significance of all that for grieving. But almost every witness who came here complained about the fact that whether Takalani or something angels, I don't know how they call it, precious angels, name it, they get there. There's just nobody appointed, accountable, just to say what happened. Why is it so? Do you know?
Yes, I know. I think this is the difference between professional care and what I call fly-by-night care. I mean, I heard this during the testimony where, I mean, if you went into a hospital, you know this, there are always nurses walking around, they come and take your blood pressure, take your pulse, and so there's always somebody around to do that. If you went into an NGO where people don't know, first of all, even if you said to them somebody was suffering from epilepsy, they don't understand what it means. If you gave them a medical records, they don't know how to read it, and sometimes part of the complaints that people didn't come with records is that even when they came with a summary of medical, they didn't know how to interpret it. So the ignorance in the system compounds the problem. And of course, all they can say, you know, the average healthcare only recognizes a medical file if it looks like a file. If somebody has written a letter, a summary, they're not going to be able to interpret that as to what it means. So I think one has to be careful when you hear that there were no clinical records, because clinical notes were made, and doctors operate through clinical notes to each other. And if you know what it means, you read the clinical notes and you pick up a phone and say, can you explain this to me? But if you've got no idea that this is a clinical note, you just look at it, it's a piece of paper, and you go and file it. So you have this, there's a conundrum of that. But I heard repeatedly, like you're hearing, that we found somebody dead in the morning. Now I'm asking, where were you? I was at home. So as I say, a qualified person would not say that.
But at the point of trying to find the body or to inquire about the death, shouldn't there be a points person, the person who says, sorry, she died, and she died of this, and she died here at this time, in this way? That's a significant part of closure, and I found many witnesses complaining about just the absence of those final rights, that courtesy. After the devastation, there's no courtesy to say, and some would say, yesterday was evidence, get into that room, and the family member alone walks into a room to find the corpse of a loved one on the floor. Sometimes covered, sometimes not covered. Isn't there practice that's required to be able to convey this terrible news to a family member?
But there is
within your profession?
No, there is a practice. I mean, in my profession, it gets done. That's why I keep coming back to places like Sterkfontein and Westkoppies. You didn't hear anybody who died at Sterkfontein or at Westkoppies where you would not have an explanation that was somebody, and this is what we tried to do. We either did a cardiopulmonary resuscitation or something like that. But in the NGO, They don't know. And I think as soon as they are confronted with that question here, they are scared that you would ask them, then what did you do? You would ask them, that question is logical. If somebody says, you know, you saw my dad dying, did he say anything, or what? You don't want to get involved. The best thing is to say, we just found him dead in his sleep or something like that. Then nobody is responsible. But that is the distinction between professional quality care and what we saw in the NGOs. And it comes up repeatedly.
Counsel, Advocate Kraus.
Thank you, Justice Moseneke. Professor, as you know, none of our clients had died. So the questions that I'm asking you is to just try and see how this could not happen to our clients that are still alive. And you've referred to many studies. We haven't studied your report, as you well know, and I haven't seen those studies at all. But what I have come across in my preparation is the World Health Organization in November 2015 bringing out a report on multi-level or the risk in excess mortality in persons with severe mental disorders. Are you aware of that report?
Yes,
And they divide, I just want to hear your opinion on this. They divide the risk factors into 3 groups. The first would be the individual factors, such as which is disorder specific, or behavior factors. And we're not dealing with those now.
Yeah.
Then the second risk factors that they have is the health system factors. And I want to deal with them with you now. And the third group is the social determinants of health. And we're also not dealing with those specifically now. I just want to have your view in order to make sure that this does not happen again. Now, one of the first risk factors, and that would ultimately become then a risk intervention, is that of leadership. And they specifically list the absence of relevant policies and guidelines. Would you say that's something that is missing with South Africa?
No,
with our patients?
No, I think we have policies. It's the misapplication of policy. Now, let me give you an example in relation to this. You know, the Mental Health Care Act and its strategy says that we must deinstitutionalize, which means we must take patients from institutions into the future, into their communities and integrate them into communities. We must place them in situations which are less restrictive. Those are the basic things, and we must obviously still respect the Constitution that we must provide health care that can be constitutionally justified. What did we do in this situation here? We took patients from a properly licensed institution and took them to places that are not licensed. So we didn't fulfill that. Secondly, we took a child from Soweto, placed them in Cullinan. Now, which community can that child integrate in if they are in Cullinan instead of maybe somewhere here in Soweto? So we have breached that.
That is a United Nations principle as well, that you don't do that.
So that's why I'm saying that the policy is there, the interpretation of it. And then you go and take somebody who was at Life Esidimeni where they had a few gardens here and there, maybe ducks swimming and so forth, and then you put them into a house which is overcrowded. So how less restrictive is that?
So what you're saying, if I can just summarize, Professor, is that you say there are policies
Well, misapplying them.
which weren't applied.
Yeah.
So the leadership was lacking in the access.
I think it's an
mortality.
understatement. There is no leadership. No, lacking is a very euphemistic.
And then the next risk factor is the financing, and they list the low investment in quality care. So, and that goes with what you've said all along. If we have to deinstitutionalize, there needs to be an injection of finances.
Yeah.
And that's missing.
That's correct. I have to repeat this. Primary health care, it's very expensive. It's not cheap. You know, people, when you use the word primary, they think of themselves at primary school and, you know, mommy taking them there. And primary health care is a very expensive business if it must have quality and provide and serve the purpose that it's designed for. It's a very, very expensive thing to do. And I think in the few countries where deinstitutionalization has been done, the investment has been very heavy. And it takes time before you reap the benefits of that investment. Now, in South Africa, sometimes we think, you know, we can have an idea and do it on the cheap and it will work. And I think that's what happened here.
The next risk factor is in service delivery, and it says lack of care coordination and management and limited access to services and virtualization and fragmentation of health services. And we've seen this in the Marathon Project.
Yeah.
People were sent to places, they weren't connected with regional hospitals, they weren't connected, or they thought that the primary health care system, the clinics would give medicine which they couldn't give given.
Yeah.
So you would agree that this is a definite risk
Yeah,
in the
it's,
further
it's a
management.
huge risk. Yeah.
Professor, the fourth risk factor is that of human resources, and they list poor quality service provision, negative beliefs or attitude of the workforce, and poor communication. What would your comment be on that in relation to the Marathon Project?
I think I don't want to be targeted, but you know, I've lived abroad for a very long time, and the work ethic in our country does worry me, especially the work ethic around caring for patients. You know, I think that has deteriorated. It needs to be corrected, but that's a national issue rather than maybe specific. So I think people in the Marathon Project were just behaving like I would say we all behave.
Professor, if I can then just very quickly go over to our international obligations, and you're well aware of the Convention on the Rights of
Yeah.
Persons with Disabilities. I'll start with that one.
Yeah.
Now, Article 3 of that says that there should be respect for inherent dignity. And this didn't happen here. Do you agree?
Well, it's there in my report. There was total disrespect for human dignity. It was not there. I mean, how can people, loved ones die and the relatives are not informed? How can people be transferred in such a, almost like a legalistic manner, but the relatives have not been taken into account just to inform them we're going to transfer your mom or your sister or something? I mean, all of these things happened in this project. And the sad part is, it was being done by professionals.
Professor, and then Article 10 says that people with disabilities have an equal basis for their right to life, which is logical or should be logical to us.
Yeah.
But that didn't happen either.
No.
And you've no doubt also looked at the UN principles for the protection of people with mental illnesses and the promotion of mental health when you did your report.
Yes, that's correct.
And Principle 8 states that the standard of care should be similar to other health institutions. If I'm sick, I should get the same treatment as a person with, or other way around. A person with mental disabilities must get exactly the same
You
treatment.
mean
as
the
a-
same quality of
Same quality, yes. Thank you, Justice.
Well,
That goes without saying, actually.
it
It's
goes
just
without
that-
saying, but you see, what is interesting in this project is that I think it's both the MEC and the Director of Mental Health went around telling patients that they would get good quality treatment when they live Life Esidimeni. It would be either equivalent or even better. I think that is on record in various documents. But in reality, what you are now hearing and what has been the experience is totally different. So I think as lawyers, we have a name for it. I don't know what it is, but I don't have it.
Then just, I'm very nearly finished with you, Professor, but Principle 10 says that all medication should
Well,
be
the
recorded.
word is misrepresentation, Professor. I know you know it, but you won't say it yourself.
It's called perjury.
Principle 10 says that all medicine must be recorded on the patient's record. That also goes without saying, but that didn't happen here.
No, they didn't. There was no records, but the worst part is that the patients didn't get medication. In fact, some of them relapsed, and they had to be, almost treated physically because they were not receiving any medications. There was no record what they had got, and I'm sure you'll hear it. I think as you carry on here that people were not receiving medication.
Or the correct medication.
Yeah,
for that matter.
or but also the people who were giving the medication didn't even know how to read what was to be given. So you had all kinds of issues that relate to professional understanding of what these people needed.
Yes.
As opposed to, as I say, fly-by-night caregivers. Doesn't work.
Professor, our clients would want to also know if you've discovered on what basis patients been, for instance, sent to NGOs or to government institutions. Were there any rational manner in which that had occurred?
Yeah, I think there were 5 psychiatrists that were working at Life Esidimeni that I called during my investigation, and I think there is in part of my findings, I actually document what they said. One of the things that they said to me was that as part of a team to assist in the assessment of where patients should be, they assessed that people who seemed to urgently require medical attentions would go to hospitals. And those that were, some of them were frail, but they felt that they were stable, they would go to NGOs. That was the one response. The strongest response that I got was almost like diametrical. One of the psychiatrists actually said, this project is such madness that I'm resigning, and she resigned because she didn't want to be associated with it. Another one said, because we knew that this place was closing, we had to do what was best for patients, but we did not send anybody that we thought was dying to an NGO. So as far as they were concerned, the people who went to NGOs were reasonably fit enough to survive there. Now that also begs the question, why did they then die in such large numbers if they were of that quality? But we now know that I'm sure if all these patients had gone to Vescopis, I suspect most of them would be alive now.
Can I just clarify the question a little bit further? I hear what you're saying about patients going to hospital, but were there any differentiation between patients going to Siabedinga and Cullinan, for instance? Were there any rationale in placing those?
As I say, there were 2 clinical teams that were based at Life Esidimeni that was supposed to assess patients as to where they would go. So they did the assessments. But unfortunately, the director of mental health changed that anytime she wanted to. So patients arrived at the CCRC, and she would decide, no, they must go to Precious Angels.
Yeah, but Professor, the question, the cutting end of the question is, once the initial grading, if you like, had happened,
Yes.
what was the rational basis for choosing Precious Angels or Siabedinga or Takalani, or I think that's where council is going to.
I don't think.
Once that left Life Esidimeni, which was being shut down, what was the criteria for basically sizing up and cutting up the cohort remaining.
I think it's fair to say, just as we did not know why Precious Angel was chosen as an NGO, we don't know the criteria that was used to send patients there. I did try and canvass it with one of the people, and you know what was the answer? They were better qualified such that we could send patients there. That was the answer I got.
Can you just repeat that? I didn't hear that, Professor.
When I asked, why did these patients go to Precious Angels and the patients and leave CCRC? And the answer was that Precious Angel was better qualified to look after them. But the criteria actually for sending a patient to Siabadinga as opposed to was never known. Just as we did not understand the criteria for licensing or for providing anchor, taking it from Kalafong and putting it into CCRC, and you don't inspect that it deserves to be there. So there were always these things that were almost like ad hoc.
Without rational basis.
Yeah.
Thank you, Justice. I have no further questions.
Thank you.
Thank you, Justice.
Counsel, please go ahead.
We have no questions for the professors, save for thanking him for all the work he has done. We have no questions for the witness.
Yeah, you've been smiling throughout his testimony.
Chief Justice, I included some of his patients. I've included them, I know how to deal with them.
Indeed,
I think
sir.
it's that little, I saw those quotations that associated, deaths that has given a smile to you, counsel. That is fine. Advocate Kuchana, I'll come back to you last. I must go to the state. Advocate Utamu.
Thank you, Justice. Good day, Professor Makgoba.
Good day.
Is it correct that Sterkfontein and Weskoppies are state institutions?
That's correct.
And you have lamented the fact that the general population of our country accept mediocrity due to the history of oppression and suffering.
Yeah, I think as long as you remember that I'm not a sociologist, I just had to find, I'm trying to explain to myself what makes us accept mediocrity so easy as a country. And maybe I think it has to do with our history rather than anything else, yeah.
Okay. And in relation to that, you have identified Sterkfontein and or Weskoppies as the standard at which the level of care can be measured.
I've done that. I've not only compared them with ourselves, I've benchmarked them internationally. As I say, if you look at Weskoppies did looked at mortality over a 5-year period in 2010, and their standard mortality rate is the lowest in the world. It's normal, let's put it that way. In fact, if you had to calculate it, if you were in Weskoppies and you were mentally ill, you would have a normal lifespan. That's how good they are. And that's how I've benchmarked them as the standard that we must aim towards. Because they are with us, they are doing the work in our own country. Other people are benchmarking themselves against them, but we are benchmarking ourselves against other things.
And do I understand you to be saying that Weskoppies as a state institution offers the best care even compared to internationally?
That's what the studies have shown.
We now know that we have experienced a tragedy that should have been avoided. And in your report, the final summary which has been presented today. In fact, at page 6, you have mentioned that the National Minister, the Premier, the MEC, and all professionals and staff involved in this mammoth relocation project, they have provided care. In fact, if I can just start all over again to read for the record. The National Minister, the Premier, the MEC, and all professionals, staff involved in this mammoth relocation project, and staff who have provided care should be complimented for bringing back dignity and pride to South Africa. And towards the end of that paragraph, you have recorded that we stopped the unnecessary death of mentally ill patients and should now maintain the highest standard of care they deserve and that we are capable of. So, do I understand you to be saying that the leadership has managed to arrest the situation and avoid unnecessary death of these people?
Well, I am saying that since the release of my report and the galvanizing of the Premier's office and the national ministers and their respective DGs, and by assembling all the capacity and the expertise that we have, I think we have been able to go back to basics and do things the right way. And that right way is reflected actually at the precipitous death of patients following the relocation. And that, you know, if you were to calculate that number of 2.7 and just multiply it by 12, you know, you will find that you are having maybe about 30 patients or 32 patients that would, of that severity, to die. You won't find that in many places in the world at such institutions. So the standard is there, and as I say, adverse copies, they attain that all the time. So it's not like, you know, we must send a delegation to go to Amsterdam or to go to, you know, Connecticut to go and study. We have two institutions here that are doing it, and they're doing it, we have had to galvanize them. But people had to do what they're doing in order to get the minister and the premier to move. Because at that time, before that, they were blocked. And I'm saying that I think the experience of the last 6 months has shown that we can do things, we can do them properly. And I suspect that looking at the number of deaths that are occurring now, I think we are almost close to reaching a point where, remember that you can never stop death completely. But if I was to calculate, for example, I told you that if you looked at the cohort of 2016 where 103 patients died, okay, in that year, and then it would have represented an 8-fold increase above the general population. Now, if you have in 2017, you have 30 people die over that year. You know, you have almost reduced that by a third. Now, it would translate into 63 divided by almost 3. You have an age-adjusted rate of about 20, as opposed to 63. So, and it's almost just twice the general population. So you can reduce it. And I can only give you an example. During the epidemic of AIDS, you know, the age-adjusted mortality in the country was about 14, between 13 and 14. So you are not far from something that has happened during a major disaster in our country if you can cut that down to less than 20. In fact, South Africa's neonatal mortality is about 20 per 1,000 live births. So we already have such figures here. It's reducing all the time, but if you could cut the death of these mentally ill patients and bring it to something that is acceptable, I think, which is what has happened here, I think that would be good.
Essentially, like you state that since the release of your report, things have been done correctly after the release of your report.
I think maybe correctly is not something, I haven't gone to evaluate, but things, yeah, people have been busy and there are some good results, but I haven't evaluated them so strictly that I can say correctly. I think, let's say, we have made an effort and that we have been rewarded for that effort.
There has
I
been
think, Council, you want to locate your question within the ADR period,
Yeah.
alternatively within the Ombuds investigation period. He's rightly reluctant to talk generically about mental health care in the country now. Do you want to phrase the question in a way that, in other words, is more relevant to the arbitration?
Professor, will it be correct that since the release of your report, and as per your recommendation, the government has indeed taken appropriate measures to improve the health care of mentally ill patients?
Yes, I think I would agree with that. I just hope that when this process finishes, they don't sleep again.
And in conclusion, from what you have just said, I just want to refer to page 6 of your, page 7 of your latest report, where you have stated that for disinstitutionalization to succeed and match the best healthcare standards, community-based mental health care services must be developed and properly resourced to the level of the standard of care existent in our current institutions in South Africa, such as Weskoppies and Sterkfontein. Will it be a correct assessment that if the government commit itself to the standard already set at this institution, the tragedy that we have experienced will never be repeated?
In medicine, we don't use the word never. It just doesn't, life doesn't work that way. I mean, I can only say that it is less likely to happen. I can never use the word never.
Will it be unlikely that that tragedy that like we have just experienced will reoccur?
It's unlikely, but not, the word never is too strong. Only politicians use the word never, but it doesn't matter to them. There are no consequences.
Thank you, Professor. There are no further questions.
Yes, re-examination.
Thank you, Justice Msaka. Nothing in re-exam.
No. Nora leboga gape Sebat.
No, thank you very much.
Lebogile. Amanchiao.
Thank you.
Unless you want to say your swan song, but
No.
we're appreciative of the work you've done. Most council have said though in appreciation, and the family members even in greater appreciation,
Thank you.
because we have been set up as a consequence of your report, and we're in a journey. We'll be talking to psychologists and other experts after you, again progressing the same journey on the one end, and on the other indeed arbitrating the dispute between the parties, being what equitable redress they're entitled to after all this carnage. So that remains a legally valid inquiry that we're going through, so that soft-end issues on the one end, but the hard-end issues also, which the law recognizes that equilibrium, the scale. If it's tilted to one side, the law tries to tilt the scale back. So there will be attempts to find equitable redress. And you've done a lot to help us get there.
Thank you. I appreciate that, and I hope that the families really do find that there is a different commitment that they are seeing, and hopefully it will be maintained into the future. And we, sometimes we think that the government doesn't listen. I think there are some people in government who do listen, and I think we must also recognize that it's not a monolithic structure. It is diverse, and I think we must appreciate what has been done so far, and let's hope they take it into the future.
Oh yes, you're so right. And government is our partner in this
Yeah.
process.
Yes.
They're not. It's a contrite state trying to do its best to arrest the carnage
Yeah.
and to stop it.
Yeah.
Yeah. Thank you.
Thanks.
Counsel, you're excused, Professor. You may leave.
Justice Mseneke, that is it from us for now. We'll hand it over to Section 27 to take over.
Very well. Thank you. Advocate Hassan.
Justice, before we call our next witness, I'd like leave to hand in another exhibit. It's not for the purposes of today's testimony, but it will be for the purposes of the testimony of the expert to come on Monday. And I thought it best that all parties have a copy before Monday.
Any objection to handing up the summary of the evidence for Monday?
So this is not the summary of the evidence. It's a document to which the expert will refer. That's not currently in his report.
I follow.
We'd like to call Ms. Coralie Trotter.
King or a viewer, could you give me the report, please? Ms. Trotter, would you put your full names on record?
Coralie Ann Trotter.
In which language do you want to testify?
English.
English. Do you have an option to affirm or to swear to the truth of your evidence?
Either is fine.
Okay. Do you swear that the evidence you are about to give will be the truth, nothing but the truth? And if so, please raise your right hand and say, "So help me God."
So help me God.
Very well.
Thank you,
Counsel.
Justice. Good afternoon, Ms. Trotter. We're going to begin with, just for the record, reference to your CV and your expertise as a clinical psychologist. Your CV is contained in volume 11, which Obakeng will assist you with. If you could turn to page 3635. Is that your CV?
It is.
And according to your CV, you have a master's in clinical psychology. Is that correct?
That's correct.
And this was awarded to you in 1995 by the University of Witwatersrand.
Correct.
You also have a BA Honours in Applied Psychology cum laude.
Correct.
And you graduated from that degree in 1990 from the University of the Witwatersrand.
Correct.
I'm not going to go through all of your...
No, let's find out if any of the council contests that this Ms. Trotter is an expert in the field she's about to testify on.
Thank you, Justice. We're not disputing that.
You're not disputing that, are you, Councillor?
We're not disputing. Thanks.
No dispute.
Yes, very well. I think I've looked at the CV and I'm satisfied that you're properly qualified. I think we should go ahead to the substance of Ms. Trotter's evidence.
Just before we do so, Justice, you will also see in the same volume from page 3639 all the way up to page 3731. There are a series of CVs. I'm just bringing it to your attention for the record. I will not be referring to them, but there were a number of people who were involved in the preparation of the expert report in consultation with the families, all of whom are experts in their own right. And so we've attached the CVs for the record, although we don't need to qualify them for these purposes.
I've seen from her report, she has several expert collaborators, and her report should suffice.
Correct.
If there's need to call any of the other experts, of course we'll do so. But I think for now, her qualifications should be good enough.
Thank you, Justice. We can turn then to the report that's been prepared by Ms. Trotter, which is contained in ELA 56. As I pointed out yesterday, there are some minor amendments that have been made to the report, and so we would prefer to use this version rather than the one that's already been included in the bundles. So it's ELA 56.
And you have a copy of
I have that copy,
before it.
yes.
Very well. You may proceed, please.
And it's entitled Expert Testimony for the Alternative Dispute Resolution Process with Justice Dikgang Moseneke. And it says led by Coralie Trotter. Was this report prepared by you?
It was prepared, yeah, yes.
And this report is based on the work of the team of individuals you mention on page 5, is that right?
Correct.
Can you tell us when the team began its work?
The email arrived from Ms. Rujeje on the 22nd of August, and over the next week I mobilized a group together and we began about 10 days later. Firstly, thinking through how we were going to go about it, and then we set up a schedule of interviews.
What was the objective of your project with the rest of the team?
It was to try and understand how the individual members of the families had experienced this entire process from the very beginning, and to look at the impact that it had had on them, and then also to formulate an argument in terms of why that impact was so devastating. So the information essentially came from the families, but then it was pulled together in a particular way to create an argument.
Before we go into the findings of the team, can you briefly explain to us what was the process you followed?
With the team.
Yes.
In our first meeting, we spent a considerable amount of time thinking about what this kind of intervention would look like, because the circumstances are very specific and unique and also complex. And so one of the things we realized was that we couldn't see this simply as a means of getting information from the family members for a report. That in fact, these families are so traumatized that we had to approach everything as an intervention in and of itself. and that our priority throughout had to be the well-being of the families, and that had to be taken into account first and foremost, and then we needed to try and, at the same time, access information. So we developed a model. It's called a single therapeutic interview, and really what that means is that you go through a consultation, and it must be complete in itself, so that you're not leaving things open-ended, but there must also be the opportunity for follow-up.
And I noted on page 7 of the report, the paginated page 7, Justice Moseneke,
Yes.
page 5 of the report itself, that you invited independent peer review of the
Yes.
process.
Yes.
Can you explain why you thought that was necessary?
Ms. Rujeje's initial email to me disappeared into virtual reality, and then she was very persistent in terms of phoning me and WhatsApping me. The email arrived again, and I got the shock of my life when I realized what she was asking for help with. So my concern was that, that if Ms. Rujeje had not persisted, that email, I wouldn't have known that it had ever arrived, and it would have been another instance of the families being dropped. So what I was worried about while we were going through this is that that potential was there all the time, and so we needed independent review of where we were at, how we were thinking, what we were doing, to make sure that we didn't let an organization, an individual, or a family down. And Ms. Yasmin Karam, who is an attorney, yeah, and Professor Mark Soames both agreed to do that. He's a psychoanalyst, and he's just won the award for Outstanding Scientific Achievement internationally and the FEFA Prize. And they both agreed to read the protocol before we started the interviews, read the report, and just basically check that we weren't dropping balls.
Thank you.
Just before you go ahead, something I should have asked earlier. How was the team constituted?
Basically what happened is I do a lot
In
of...
other words, from what pool, from
Pool,
what
yeah.
institution, what place did you draw
Yeah.
the team?
I run a series of reading groups which study psychoanalysis, and there are about 60 psychologists who are active in those groups all the time, 5 groups, and then a lot of people who were part and have left but still attend workshops. And so originally I sent an email out to that whole group, and I have obviously very good relationships with them. And then separately from that, I phoned other individuals who
Are
have...
they a group of practicing psychoanalysts? Are they a group of academics? Are they... I just want to get a feel
Yeah.
for the team.
They're all mental health professionals, so they all have a registration with a body. They are all practicing, and they all work psychoanalytically. So they're not all psychoanalysts. People have different qualifications, but the way that they're working is psychoanalytic,
Yeah,
working with the depths.
that's good enough. Thank you.
Yeah.
Thank you, Justice. Is there anything else you would like to say about that, about the team and the makeup, before we move on to the report?
Just in terms of, the possibility of dropping a ball, the other thing we agreed on was that 2 clinicians would be in every single interview. Obviously, we were managing language. That was one consideration. But we also thought that with 2 people there, it would help in terms of interviewing, intervening, note-taking, because obviously we needed to get the information down, but if we needed to interview and intervene, in between that, we were going to do it all. So that was another thing we did, and I think that helped a lot. The clinicians afterwards said that they didn't think they would have been able to do those interviews alone, because they were so highly charged and difficult, painful.
On page 6, you talk about a representative group of people, of families.
Yes.
And this boiled down to 11 families. Why were these representative? I wondered.
Council would have to answer that question. Are you meaning in terms of the group of 56 or why those 11 were chosen?
You see, your evidence stretches out to all victim families.
Yes.
And the conclusions you reach are premised on talking to 11 families. So the rational and logical thing is to ask us to say, why were these families represented? I don't say they are not.
Yeah.
I just want to understand the methodology and the reason why you think it's appropriate to have these families represent
a big group.
Yes.
So the model that we used, it's a kind of research, it's called qualitative research. And really what that's about is trying to get inside the skin of the person who's had the experience and look at it from their point of view, as opposed to standing on the outside and from the outside trying to measure something. And with that way of researching and interviewing, you can get much more information because you can go deeper, you can explore, you can also look at nonverbal behavior, and you're looking for themes. So ideally, it doesn't matter if you're family number 1 or 11 or 54. You would expect to find the same themes if you've done the interviewing skillfully enough and effectively enough.
Yeah, so you're saying it's not a matter of voting, it's a matter of extracting themes.
Exactly.
Themes of experience.
Yeah.
Are they?
And then you can see differences. So there are some differences in the families. There was someone we interviewed who was not traumatized, but that was an outlier. And for the rest, the themes kept coming up in different words, different ways, but it was all sitting in the material, in the reports I was given.
The reports you were given, together with the interviews with these 11 families, was that sufficient for you and the entire team to draw conclusions in respect of all of the families that were affected by the transfer?
We had read the Ombuds report, so we had that as a gestalt, as an overview, a lot of the affidavits. Then we did the interviews, and I had all the reports, and I could ask the clinicians for more information. So I could go through a report and then send an email to everyone and say, I want to know your experience of what it was like, or answer this, or give me this. So in a way, once you've sat through the consultation, there's a never-ending amount of information that you can access. So that felt for me absolutely enough to write the report. But then there is not a single moment of this arbitration that I've missed. And so if there were contradictions, I would be well aware of that by now in terms of listening to whatever. And in fact, what's happened, it's reinforced what I've written in the report, the process of the arbitration.
Are you saying that all of the findings in this report are applicable to the all the findings applicable to all the families who've been affected?
There might be a few where there's variation, but I'm absolutely convinced that this applies to the families, all of the families.
And all your colleagues as part of the team agree with you?
Absolutely.
So let's begin with your report. You start off your report with an introduction, and in the introduction you refer to the concept of home. Can you explain why you do this?
I think what happened here is complex in terms of trying to make sense of it. So I think what I was trying to do the whole time is get under what we had observed and try and understand really what went wrong. And in my mind, because this was a decanting, a relocation, it had to start with the place that we live in and what it means to live in that place. And so that's why I started with the idea of home being so important in our lives, materially, psychologically, and that any experience of a home, even though it's not ideal, leaves us with some a substratum of identity, meaning, humanity, a sense of belonging, and it's so fundamental that usually it's out of the reach of awareness. The point I was trying to make is belonging to a place or having a sense of place is so important that in war zones, people feel safe if they are attached to a particular place. That's how powerful it is. And so then if you start disrupting that, it's considered to be one of the most severe social stresses that you can encounter in life, is to lose your home.
Most severe social stress for anybody, would
For
you say?
anybody.
It's even more so in the case of mental health care users.
Well, that then exactly becomes the point, that if you've been institutionalized, you've already lost a home, and you've already had to rebuild a sense of place. So once you lose a home, rebuilding that sense of place is absolutely critical. And being who we are able to do that. So refugees, people who relocated, as long as they form intimate, meaningful relationships in a place that breeds familiarity, they'll rebuild a sense of home. And there's a psychoanalyst, his name is Henri Ray, and what he realized in his work is that place, that rebuilding a sense of place for psychiatric patients is so important that the building itself comes to be called, for him, a brick mother. That the actual building is a brick mother and provides a sense of security, sense of safety, protection, there's involvement in it. So it is actually the building itself that can then hold the patient together. So if you're going to move someone out of a place that for them has become meaningful, a brick mother, where the guard you have a relationship with at the gate, for example, and with all the other patients and with the staff, if you're going to disrupt that, you have to be very, very careful about it.
So this was a very important context for the rest of your
Exactly.
report. Your report.
Well, Council, I'm going to interrupt you because on that note, I'm going to adjourn for the lunch break from 1:30 to 2:30. And I think we have set the mother brick in place. And we're going to come back and traverse this on a lighter note, and maybe not so lighter note. I do know something about being decanted, losing a home,
Forced removals.
and struggling to find a new home. I do know something about that. But thank you, and we're going to resume at 2:30.
Thank you.
Very well.
I'm looking for Pat's file. No, then Pat, you didn't forget it in the office.
I think you did. I think Jack forgot his.
Oh, is this yours? You marked pages. No, then it's not yours. Because I thought then maybe that I picked it up together with the judge's. I said you should have. No, it's not in the office. I checked. Countless times. Indeed, good afternoon to you and to our viewers at home. Yesterday we did have family members contribute their testimonies, relaying what happened after they were told that their loved ones had passed on. This morning we opened with former Health Ombudsman attorneys actually informing the arbitration that she'll only be available next year in January. This because she is still at school and also that they're challenging her suspension from the school. However, we have heard from the Health Ombudsman, Professor Makgoba, that the number is actually at 144. We came to this number because 180 patients died between his investigation period and 21 died after his investigation and 4 patients died while they were moved back to professional health care facilities. So we are moving forward with the clinical psychologist who will also give us her testimony as to how they got information from families, how they were treated. Ms. Trotter, who is a clinical psychologist, just before the adjournment, mentioned that moving mentally ill patients in the way that they were moved is actually disturbing to their minds because they are used to a certain building. So moving them the way that they moved actually did disturb their mental state at that time, hence leading to some of them relapsing and eventually dying. Indeed, she got emotional because she was recalling the times that she had to meet with the families. Remember, she had to evaluate certain family members and make sure that they are actually suitable to come and testify. And she says that this process was actually rushed and hence a lot of people actually died because of the way in which it was done. This actually tempered with their mental state, moving them the way that they did. And recalling some of the testimonies that she heard from the families and evaluating them at that time, I think it also took her back to the times that she had to spend with family members and actually listening to their testimonies at that time. The proceedings indeed will continue at 2:30. They only adjourn for a lunch break and will continue immediately after the lunch break with Ms. Trotter giving us explanation of how she came to a conclusion in her report that is being used to actually cross-examine her. So far, she has been examined by Section 27's advocate Hassi, and we'll hear from legal aid lawyers, the state, and also Solidarity and Evidence in this.
So you were live?
It was alive.
Yeah? It was alive?
Yeah. Was the phone bad?
Ah,
It wasn't that bad.
not that bad.
Yeah, the light actually went down. It's not that bad.